My name is Jens Wanscher. I'm an ENT doctor. I work at Odense University Hospital and University of Southern Denmark. In this video, I'll go through an examination of the patient suffering from acute vertigo or dizziness. Objective tests done by an ENT doctor. However, the test can easily be done by doctors from other specialties, such as in the emergency room or by the general practitioner. Besides the test I show, the patient should be thoroughly interviewed about their prior medical history and present symptoms, as well as have neurological examination, otoneurological examination, basic ENT examination, cardiopulmonary examination, as well as possible blood samples and radiological examinations as well. ENT doctors may use many other tests. However, these tests I show are in most cases sufficient. As an introduction, I'll just talk shortly about the vestibular reflexes or pathways. In several of the mentioned tests, we utilize the fact that nerve fibers connect the vestibular organ in the inner ear through the vestibular branches of the 8th cranial nerve, the brainstem, and the 3rd, 4th, and 6th cranial nerves with the external eye muscles. These connections are termed the vestibular ocular reflexes and gives us the ability to keep our vision steady and focused on objects in our surroundings despite moving the head, even vividly. In case of pathology affecting any part of the VOR pathways, it can result in vertigo, dizziness, nystagmus, and or difficulties in keeping our eyes focused. As a byproduct of pathology affecting the vestibular pathways, we have the so-called vestibular autonomic reflexes that can make us feel nausea with or without vomiting. Finally, we are equipped with connections between the vestibular organ in the inner ear, brainstem, cerebellum, and proprioceptive receptors of the spinal column, hips, knees, ankles, as well as under the feet. These connections, called the vestibular spinal reflex pathways, are capable of initiating reflective contractions and relaxations of relevant muscles in the body when we are about to fall. It's important to emphasize that both pathology in the inner ear, along or in the vestibular nerve, as well as pathology in the central nervous system can show quite similar symptoms. However, during the mentioned tests, I'll give you some hints to separate pathology in the inner ear, the vestibular nerve, and the central nervous system. The first 4 tests, the patient can either sit in a chair or lie in a bed. The important thing is that the patient can look at your eyes when doing the tests. The first examination is examination of nystagmus. Nystagmus can be either spontaneous or non-spontaneous. In case of spontaneous nystagmus, you can look upon several parameters like direction, where it can be to the right or to the left in case of horizontal nystagmus. It can be vertical nystagmus, and it can be rotatory nystagmus, where the eyes rotate along their own axis in the anterior-posterior direction. Then you can look on amplitude of nystagmus, large and small amplitude, on frequency, high or low, and on gaze-evoked nystagmus. It can more easily be done using either Bartle's glasses or Fresnel glasses. These serve as magnifiers to see the movement of the eyes better and removes the patient's ability to suppress nystagmus. To describe the nystagmus, we can use several parameters. The first is direction of nystagmus. It can be horizontally, where the fast phase of nystagmus goes either to the right or to the left. It can be vertical nystagmus, and it can be rotatory nystagmus, where the eyes rotates along their own axis in anterior-posterior direction. The second parameter is the amplitude of nystagmus. The magnitude of movement of the eyes can be either large amplitude or small amplitude. The third parameter is the frequency of nystagmus. It can be either slow or high frequency. In case of pathology in the ear or along or in the vestibular nerve, the nystagmus is often getting worse with Barthel's or Frenzel's glasses, as well as the nystagmus is of high frequency and low amplitude. In case of pathology in the central nervous system, it's opposite. The nystagmus is as severe, nevertheless you use Barthel's or Frenzel's glasses or not. The amplitude is large and the frequency is low. This video clip shows a high frequent nystagmus with small amplitude in a combination of left beating direction with a rotatory component, as seen in case of pathology in the inner ear or along or in the vestibular nerve. The last thing to test is done without Barthel's glasses, where you look for gaze-evoked nystagmus. You ask the patient to look on the finger and do a movement so the patient looks to the right about 30 degrees, not maximally, where almost everybody will get some sort of endpoint nystagmus, only 30 degrees, and then similar to the left. If nystagmus arises here, it's evident of the pathology of the central nervous system, especially if it's with side differences. Also, if you have a spontaneous nystagmus and the nystagmus changes direction, whether you look to the left or to the right, it's indicative of pathology in the central nervous system. During the head shake test, we test different parts of the vestibular pathways. We test the lateral semicircular canal, the superior branch of the vestibular nerve, the brainstem, and the third, fourth, and sixth cranial nerves. A positive test does not indicate the location of pathology. However, it indicates the presence of pathology. I grab the patient's head and turn the head in a frequency of 2 Hz for 15 seconds. The patient shall wear the Barthel's glasses or Frenzel's glasses or similar. After 15 seconds, I'll ask the patient to look towards me through the glasses. And then I'll watch for possible nystagmus beats. If there are more than 4 beats, the test is positive and indicative of pathology to the vestibular pathways, either in the ear, vestibular nerve, or brainstem. In the head impulse test, we test the similar pathways we mentioned before under the vestibular ocular reflex. In case of a positive test, we have pathology in the inner ear or along or in the vestibular nerve. However, only seldomly pathology in the brainstem. I ask the patient to look at my nose and keep focus on my nose. Then I grab the head and turn the head slowly to the left and fast to the right. This is the test of the right vestibular ocular reflex. Then I do the opposite, turn the head slowly to the right and fast to the left. Always looking on the patient's eyes to see if focus on my nose tip is lost. This video clip shows the head impulse test towards the left, and it's negative, equivalent of a normal vestibular ocular reflex. This video clip shows the head impulse test to the right, and it's positive, equivalent of pathology in the right inner ear or along or in the right vestibular nerve. An example of a situation where the impulse test is useful. A patient presents with acute vertigo, nausea, no other symptoms, nystagmus, and no neurological symptoms, all indicative of vestibular neuritis. However, the impulse test is negative. In this case, you should suspect a possible pathology in the cerebellum. In this case, the impulse test is the only test bedside to raise suspicion of central nervous system pathology instead of vestibular neuritis. The test of screw deviation is quite simple. I ask the patient to look on my nose and keep focus on the nose. Then I cover one eye for a few seconds, and at the same time as I uncover the left eye, I cover the right eye. And then I look on the left eye if the axis of the eye is still pointing toward my nose. In case of a positive test, the eye may drift vertically as evident of pathology in the brainstem. In this case, the test is negative on both sides. No drifting in vertical direction of the axis of the eye. In the test of screw deviation, we test pathways between the vestibular organ in the ear, brainstem, and the external eye muscles that give us an ability to have parallel axis of the eyes despite covering one eye. The Dizziness test is only used if we suspect the disease BPPV, which indeed is the most common pathology of acute vertigo, as to why the test is important to know. The test is not done if the patient has spontaneous nystagmus. Why is this? BPPV does not present with spontaneous nystagmus. In this test I'll show now, I'll test the left posterior canal for BPPV. The patient wears Bartels or Fenton's glasses or similar. The examiner turns the patient's head 45 degrees toward the left ear, and in a smooth, however quite fast movement, the patient is lying down on the back on the pillow like this. In this position, the head will tilt about 30 degrees below horizontal plane. You watch the patient's eyes for nystagmus and ask the patient if he or she will become dizzy, as evident of a positive test and posterior semicircular canal BPPV on the left side. Often, in case of pathology in the semicircular canal, there is a latency of about 10 to 15 seconds before dizziness and nystagmus arises. Very seldomly a pathology in the central nervous system can yield nystagmus and dizziness in this movement. And in case of this, the dizziness and nystagmus will arise from the beginning and won't stop until another position is made of the head. At the end of the test, you assist the patient in sitting up once again. The test is done to the left side and to the right side. There are several ways of doing the Dizziness test. This is my preferred version, because in case of a positive test, you could go immediately to the Epley's maneuver to manage the disease. As closing remarks, patients who present with acute dizziness are very common, both at general practitioners, emergency rooms, and ENT doctors. It's mandatory to know how to diagnose these patients correctly, keeping in mind that we want to give the patients the right treatment. As to this, it's very important to spot the few patients that present with an apparent benign disease such as vestibular neuritis, but in fact are suffering from acute central nervous system pathology, such as infarction of the cerebellum. Some of the mentioned tests comprise the so-called HIMSS tests, head impulse test, alternating nystagmus on gaze-evoked nystagmus test, and test of screw deviation, which indeed seek to make it easier to diagnose patients with potentially life-threatening central nervous system pathologies. Thank you.